Okay, good afternoon, everybody. My name is Joe Peak. I'm the JBLM Installation Public Affairs Officer. Thank you for making time to be here for the Ebola Town Hall today. Just a couple of quick things. First of all, the cursory cell phone reminder. If you got cell phones, please put them on vibrate or turn them off. I know this cold weather's probably sapping the battery life right out of them anyway. And while I'm talking about cold, yesterday's town hall, we were projector challenged. Today we're heat challenged. This evening at French Theater, we're going to have heat and we're going to have a good projector. So if you want to have both, come back this evening. You can hear the same briefing again over at French Theater. Like everybody here, will be back this evening at French Theater. Okay. In a few moments, Lieutenant Colonel Markham from Madigan will be up here to do the briefing. After that, there's going to be a question and answer period. So if you have questions during his briefing, just make a note of those to yourself or write them, on your hand or something. And then we'll have a microphone here and up here in the front. After we get done, you'll be able to come forward and ask those questions. Just so you know, the session today is being recorded, and then at the end of the week, we're going to put links to all 4 of the town halls on the JBLM Facebook page if you want to go back and watch those. And that is it. So with no further ado, Colonel Hodges, JBLM Commander.
Just very, very briefly, today is about education and information, okay? So I want to make sure that do not walk out of here today. If you have a question, come up and ask it, okay? So if you walk out here going, wow, I'm wondering about that, I'm wondering about this, then we failed you. So get up here. We got the experts here. Colonel Markham yesterday, fantastic job, nothing but positive comments, and he will fill you in. He has more information than any of the rest of us up here in the front row have together. So without further ado, Colonel Markham, it's all yours.
Well, on behalf of the Joint Base leadership, Madigan, and the entire Madigan Healthcare team, I want to thank everybody for taking time out of your busy schedules to join us for a dialogue about Ebola virus disease today. As alluded to, I am Rod Markham. I'm one of Madigan's preventive medicine physicians and the hospital's public health emergency officer. In that capacity, over the past few weeks, I've been working with a large team of individuals to synchronize our planning efforts with regard to Ebola response with those of our local and state public health authorities to make sure that our plan syncs with the guidance that's been prepared or been provided to us from the Department of Defense and the Centers for Disease Control and Prevention. What I'd like to do today for a few moments is summarize some of the key aspects of the virus, its disease in humans. We'll describe some measures preparing and protecting our individual service members deploying to West Africa in support of Operation United Assistance. I'll highlight what Madigan has done to prepare its facility and staff in the unlikely event that we have to take care of a potential Ebola patient. And then lastly, we'll talk about what we can do together moving forward. Since its discovery along the banks of the Ebola River in the Democratic Republic of the Congo in 1976, the Ebola virus has been responsible for around 20 to 24 different outbreaks, or what we refer to as clusters. These clusters occurred in Central Africa in very remote locations that were largely inaccessible with small populations. So they generally didn't cause large numbers of infections or fatalities, and they tended to run their own course without spreading. Unfortunately, over the last 6 months, we found infections in West Africa for the first time. And that's significant because West Africa has a much more robust infrastructure. There's a lot of roads, there's transit abilities, there's airports, there's ports, but most importantly, there are large, dense population centers, very large capital cities. And over the last 6 months, we have seen cases into these large capital cities, and it has resulted in the largest outbreak of Ebola that we've known to date. The virus is a very significant hazard. However, it does have some vulnerabilities, and we like to leverage these vulnerabilities when we implement very rigid public health control measures. The most important of these vulnerabilities is the fact that it is challenging, it is difficult to transmit the virus between humans through routine casual interaction. In order for somebody to become infected with Ebola, you have to have direct contact with an infected and symptomatic individual's blood or body fluids. And that contact has to occur on a portion of your body that's not intact. Your skin isn't intact through a cut, an abrasion, a scratch, etc., or an unprotected mucous membrane, like your eyes, your nose, or your mouth. We have a great example of just how challenging it actually is to transmit this virus through routine casual interaction here domestically. Approximately a month ago, there was a Liberian national that came to visit family in the United States in Dallas, Texas. He had a number of high-risk exposures. While he was there, he interacted with 4 family members or 4 relatives, 2 children and 2 adults. During 5 to 6 days of that time he was there, he was very symptomatic from the Ebola virus. That virus, at the time, he was nauseous and vomiting. He was suffering from diarrhea. But even after that 5 days of close interaction in a confined small apartment with these family members, none of those individuals developed Ebola virus disease. And that's very important. And it demonstrates just how challenging it can be to transmit this virus between humans in routine casual interaction. The virus is not transmitted through the air like the common cold or influenza. It is not transmitted through the bite of an insect, a flea, tick, or a mosquito. It's also not transmitted through the consumption of usual and customary food or water sources. So I think, very key points that it is relatively difficult to transmit through routine casual interaction. The disease itself, Ebola virus disease, is very serious. And to date, there are no approved or FDA licensed vaccines or therapies, no drugs to treat Ebola specifically. There are a number of good vaccine candidates and investigational agents that can be used when they're available. But what we rely on is very early and aggressive supportive care. And that supportive care takes the form of intravenous and oral fluid replacement. We monitor and replace electrolytes very closely. And if the individual requires it, we'll give them supplemental oxygen to help them through the course of the illness. And what we have seen is with these early aggressive supportive interventions, we have reduced mortality. On Tuesday, the 4th individual diagnosed with Ebola in our country, a physician that came back to the United States, to New York City, after caring for Ebola patients in one of the 3 countries, he was released from the hospital after 3 weeks of this very early and aggressive supportive interventions, and he's the 3rd of the 4 that have been diagnosed to survive their infection. Hopefully everybody can see that top bullet. This is one of the salient points I want everybody to take from this dialogue today. And that's the fact that there is a very small subset of our population that is at risk for developing Ebola virus disease. And that small subset of our population are individuals that have an appropriate travel history, meaning they've gone to one of 3 countries with ongoing transmission risk in the last 21 days. Those 3 countries are Sierra Leone, Liberia, and Guinea. With an appropriate travel history, as a clinician, what we want to do is identify symptoms. And this is another vulnerability of this virus that we take advantage of, and that's the fact that it's not transmissible unless the individual is symptomatic. One of the challenges, unfortunately, is that the symptoms of Ebola virus disease mimic a number of other infectious processes that can occur in West Africa, and during this time of year in the Northern Hemisphere, the influenza virus. Individuals will often complain of a low to moderate grade fever. They develop headache, body and joint aches. A lot of folks are very fatigued and tired. They develop stomach pain that leads to nausea, vomiting, and diarrhea. In rare cases, oftentimes in advanced disease, you can see people develop hemorrhagic or bleeding complications late in the disease process. So as a clinician, the things that I look for to demonstrate concern for potential Ebola is that important travel history to either Sierra Leone, Liberia, or Guinea in the last 21 days, and inappropriate symptoms that I just alluded to. So Operation United Assistance is the Department of Defense supporting effort to other governmental organizations, specifically USAID in this case, and other non-governmental organizations to help build capacity in West Africa, to be able to identify, take care of, bring supplies in, to increase the capacity to help address the Ebola outbreak at its source. At no point will individual service members be providing direct care to known Ebola patients, and every effort is being made to reduce the risk for any of all individuals deployed in support of Operation United Assistance so far as their Ebola exposure risk goes. Before individuals deploy, they receive extensive briefs on medical threats common to West Africa. Examples of those threats include the environment itself. This is a tropical region. Temperatures currently are up in the upper 80s to low 90s with very significant humidity. And I think today we know that that's not something any of us in the Northern Hemisphere are really comfortable with right now with this polar squeeze coming down. So the environment is a threat. There are a number of different vector-borne illnesses, meaning mosquito-borne illnesses, malaria, dengue fever. We talk to them about the protective measures and the protective posture that's important to prevent those mosquito-borne diseases. We spend a lot of time talking about Ebola and the forced health protection measures they can implement to reduce their risk appropriately. We introduce them to the monitoring that they'll undergo in theater. When they arrive into West Africa, they begin a process that includes twice daily monitoring of their temperature and symptoms. And then lastly, we provide them an opportunity to practice hands-on with their duty-specific personal protective equipment so they gain comfort and confidence with that before they deploy. Individuals returning from Operation United Assistance, nearly all will undergo a 21-day controlled monitoring process at a pre-designated military institution. What that process really amounts to is just an extension for 21 more days, the twice daily monitoring that they were undergoing and accustomed to while they were in West Africa. Once they've cleared the 21-day controlled monitoring point and are medically cleared, they will then return to their home station where they will complete the redeployment process and begin reintegration operations. I said nearly all because there are some individuals that have been identified as what we call transient in nature, meaning their exposure time in country is so low that their risk is very negligible. And instead of undergoing the 21-day controlled monitoring, what they will do is actually begin 21-day self-monitoring in coordination with their unit-level medical representation and public health authority. And I think that's important because an example of that would be our air crews flying support missions in support of Operation United Assistance. So Madigan is prepared to take care of an Ebola patient in the unlikely event that that is required. The hospital, its outlying medical and dental clinics have all instituted universal travel screening. And that's in effort to identify that small subset of our population that I alluded to that is at risk for Ebola virus disease. We've trained our frontline clinical and clerical staff on the appropriate initial measures should they find somebody that does have an appropriate travel history. They know and understand what the signs and symptoms of Ebola are. Each of these clinical environments has identified an isolation location to segregate patients and conduct enhanced screening. Each of these locations is supplied with appropriate personal protective equipment to conduct these enhanced screenings. And should somebody require admission to our hospital, we've trained over 67 to 68 individuals, a variety of different nurses, physicians, clinical support staff, and operational support staff to provide that very important early and aggressive supportive care and manage the regulated medical waste appropriately in very high levels of personal protective equipment. So this slide allows me to kind of talk through a transition that domestically we are undergoing right now in the United States with regard to Ebola response. It's been over 22 days. I think on Friday was the 22-day mark since the CDC instituted some very rigorous screening processes for all individuals, that subset of at-risk individuals coming from one of the 3 countries entering our country through one of 5 ports on the eastern seaboard, airports specifically. So we now have the ability to identify those that are at risk. They undergo an extensive screening when they come into the country. They're tested for a fever, and then they're also passed off actively to the public health entity that they will be residing in for the 21 days after having come into the country. So in essence, we've been able to identify those that are at risk, contact them on a daily basis, a process the CDC calls active daily monitoring, and we develop a plan for a very controlled movement to healthcare if that's required during their 21-day monitoring period. So I think that's very important. Together going forward, what we can do is if you have a travel history that is consistent in the last 21 days to either Sierra Leone, Liberia, or Guinea, and you're not in active contact with a public health entity, please reach out through your primary health care provider or your local public health authority, and we'll begin that dialogue and assess your risk for Ebola virus and do that active daily monitoring that's so important. And if you know anybody with a travel history that isn't currently engaged with public health, please try to get them to do the same thing and engage public health so we can monitor them actively. One way to reach, or a couple of ways actually, to reach out to public health is either through your primary care provider or during normal business hours. The TRICARE Regional Appointment Center has the ability to link you to preventive medicine on Joint Base Lewis McChord, and then subsequently the local public health agency. After hours, our main hospital line can do the same. They are able to go ahead and get a hold of us, and we can begin that dialogue to address potential Ebola risk or questions given an appropriate travel history and health concerns. So that really concludes the remarks that I had prepared. I think at this point, as a group, our intent is to try to address any questions or concerns that you might have regarding Ebola virus disease.
So thank you, Colonel Markham. At this time, if anybody here has any questions that they'd like to pose to either Lieutenant Colonel Markham or any members of the chain of command who are here, any questions at all, you're welcome to come forward and ask your questions. Yep, we've got.
My name's Brian, and I work over at Unit Movements. I have a couple of questions. Number one, is there any medications that people could be currently taking that would lower their ability to potentially connect this disease?
Okay, so the question was, if anybody here, are there medications that might help prevent infection? Is that?
Just the opposite. Is there any medications that we know of that are being currently prescribed, if we're on those medications, that would lower our immune system to catching that?
Oh, I see. Okay, so is there for example, a lot of
blood thinners, because you were talking about some of the things on there were bruising and those kind of things. If you're on blood thinners or any of that, would that potentially lower your ability to fight this off?
Right. So because the nature of this illness, and that to this point it's largely been isolated to the African continent, where there are not a lot of routine medical interventions, folks aren't on a lot of medications. I don't believe there's a lot of research or science to support that specific medications may increase your risk of developing an infection after exposure. I just don't know that there's any data to support that thought. Now, logically, most people on medications that compromise your immune system, that might impact it, but I just really don't know that there's specific data to suggest yes.
Okay, and my other question is, because where I work at, we deal with troops both coming and going. What is the current game plan for these folks, military folks, active duty, that are coming and going? How you're going to route them through here, and who is going to be dealing with them?
Okay, so the question surrounds the controlled monitoring process. And I know that from a medical perspective, and I'll speak from the medical perspective, once they arrive, they're screened immediately for evidence of a temperature or any symptoms. And then should they have either of those, they would quickly be integrated into the response process at Madigan. As
Correct,
far
but,
as
are they coming in on aircraft? Are they coming in via buses? How are they getting here before they go into that process, and who's going to be processing them, I guess is my question. Okay.
Right, great question. So the question, if you didn't hear it, was for those soldiers, sailors, airmen, Marines, DA civilians, Department of Defense civilians, contractors that are coming and going, who's processing, where are they entering? So the intent is to have them come into Gray Field, perhaps Mcchord Field. Again, asymptomatic, without symptoms. Presumption is Ebola virus negative. They will be then taken to a controlled monitoring area, which is in North Fort, for 21 and abut days till 0800 the next day. Temperatures checked twice a day to ensure that they have no fever. As you saw, there's a fever as part of this prodrome, and they have no symptoms. If someone has symptoms, they will be taken to Madigan. Colonel Fiore's team will isolate the individual, will check to see if that individual is positive for Ebola virus disease. If positive, this individual will go to a Health and Human Services approved facility. Okay, does that answer your question in general?
Yes, it does.
Okay, great question though.
And let me follow up one more thing. You know, right now, JBLM has only been, yeah, I'm cold, man. I don't care what y'all think. I'm a Florida kid. I'm from Florida. Right now, JBLM has only been identified as one of 6 DOD facilities that could possibly receive patients for the monitoring right now. So earliest possible day we could have was the 21st of November right now. But again, there are other facilities in front of us that would potentially receiving those service members back from theater. And so right now we've been given no mission of execute. You'll have them coming in there. And if that happens, by all means, we'll communicate that to everybody and make sure they're all aware.
Good day, everyone. I'm Tommy Jenkins, and we all work for Unit Movements at Fort Lewis. Will the returning personnel process through the troop holding area, or base ops, or Gray Army Airfield?
Yeah, right now the way it be is when they receive, and whether they're coming to Gray, which is where the preferable location on Mcchord is, picked up from the bus there, and then picked on a bus and then moved to the holding area.
So from plane to bus.
From plane to bus and move them right over to the holding area for this. But again, those are folks without symptoms. So these people are going to walk back from like you and I. If there's, as General Cho said, if someone's with symptoms, that's a whole different avenue approach they'll take. The folks coming back will be normal like we all are, get off the bus and then move to the holding area on Lewis North. So.
Okay, thank you.
If I could add to that too, for a moment, let's take the fact that these service members are active duty and we're supporting Operation United Assistance, and let's track one back through the Eastern Seaboard through one of the CDC's 5 screening processes in either New York, JFK we'll use for example. It's really important that everybody understands that when they would come back and be screened, they would be screened based on the absence of known exposures while they were there providing a supporting mission. They would be screened as low but not zero risk according to the CDC's protocol. And basically at that point, they would be back into the community where they would talk to public health on a daily basis after taking their own temperature twice a day. The Department of Defense has chosen to be very, very conservative and be exceptionally precautious in this endeavor. And as a result, they've chosen to, instead of having folks do this at home, do it in a co-located facility under a controlled environment. So it's really important that everybody understands that these are individuals with low but not zero risk just because they were in that country.
Did you have a follow-on?
It's okay. Wasn't that mentioned? What about returning cargo if it's been exposed to either blood, someone bleeding, or with sweat, or just from the area?
May I hear that question again? I apologize.
Cargo returning from the area, whatever area that the troops will be returning from in West Africa, exposed cargo, pallets, pallet nets, whatever.
Just regarding the cargo, and again, I just to reemphasize the risk of transmission is very, very low regarding that, and as we understand, and from Lieutenant Colonel Markham can back me up on this, it has to be in that fluid form, and so for that to actually survive within that cargo environment, it's really no risk at all. Now, should someone become, in the unlikely event that someone were to become symptomatic on the aircraft, the aircrew are trained and provided personal protective equipment in order to spill kits and everything, and guidance on how to separate that individual from the rest of the passengers and the cargo, make sure they clean it up, isolate it, and then of course when they land, medical personnel would meet that aircraft and assess both the aircrew, passengers, and cargo. So again, minimal risk. It really can't survive, on cargo. Once it dries and stuff, the Ebola virus can't survive. Lieutenant Colonel Markham, any comments on that?
Yeah, it's believed in non-porous surfaces, so hard surfaces that aren't grossly contaminated, meaning there's not a lot of evident blood or vomitus or body fluids, that the virus's maximum life of survival is up to 24 hours. It's likely shorter than that, but up to 24 hours outside on a hard surface without being grossly contaminated. So it's not something that persists in the environment for an extended period of time unless there's a large amount of body fluid there.
My question was kind of an extension of the gentleman's in back, and it concerned the aircraft itself. What check or what cleaning might be done on the aircraft after it has carried Ebola patients, even though the likelihood of an Ebola virus surviving a flight from West Africa to the Pacific Northwest is very remote. There is, I think, some public concern if there turns out to be a lot of air traffic carrying patients into here. I've had veterans from Vietnam call me up and ask me what was the likelihood of Agent Orange on an aircraft that had been to Vietnam infecting them and causing them problems many years later. So it's more of a perception problem, perhaps, than a medical problem.
Thanks, Doc. I just on that particular question, I want to go back to the distinction between asymptomatic and symptomatic in terms of the disease. So if the individuals are asymptomatic, meaning they're not showing any signs of the Ebola virus, there's really nothing to worry about in terms of the soldiers, sailors, airmen, and Marines that we are deploying back to stateside. Again, many of you guys have heard the term overabundance of caution, and that's really what this is in terms of the procedures that we've put in place. Now, with that being said, currently DOD is not transporting any passengers who are symptomatic. Passengers and folks who are redeploying from the West African region, from the 3 countries that Lieutenant Colonel Markham had spoken about, those individuals go through a pre-screening process before they get back onto the aircraft. So 12 hours prior to boarding, those passengers are checked in terms of temperature, questionnaires, and pre-screening to ensure that they are not showing any signs of the Ebola virus. But again, to reinforce, DOD at this time is not carrying any passengers that are symptomatic.
Correct, and actually both the Centers for Disease Control and the Department of Health and Human Services have agreements with, I believe, 2 civilian companies, the 2 companies that provided air evacuation for the non-governmental providers that came back and were treated at Emory. So there's a civilian platform, if not 2 platforms, that do have agreements and have had discussions as far as they're the ones that will evacuate patients with Ebola, not necessarily the DoD aircraft.
All right. Thank you, sir. Any other questions? Going once, going twice, then I'll turn it over to General Cho.
Great, thank you. Good afternoon again. And on behalf of the First Corps Commander, Lieutenant General Lanza, thanks for your presence today, your interest, and your insightful questions. If you do have further questions, I direct you to the JBLM website. Thanks again for being here today, and do try to stay warm. Enjoy the rest of your afternoon. Courage.